So now we talk about food and drug interactions. So food can either lower or higher the drug effect. Interactions can occur in the absorption, in the metabolization and elimination mainly. We have several aspects to keep in mind, such as polymedication, the health status of the individual, poorly balanced diet, therapeutic margin, and also the sustained plasma concentration, as well as the geriatric population, childhood, HIV individuals, and special regimens, such as vegan diets. Knowing that, we have a classification by time, place, effect result, and the most important one, which is what we're going to see now, the interaction mechanism. So therefore we have physicochemical, pharmacodynamics, and pharmacokinetics. Physicochemical, acid-base reactions, and inorganic ion salts. Acid-base reactions, incompatibility, insoluble salts, pH and pKa of the drug. This means that if I have an alkaline drug in an acidic medium, it will be incompatible. Therefore, I will create insoluble salts and not absorb the drug. Inorganic ion salts. This is the precipitation opposite charge. This is, for example, salt. Salt is chlorine and sodium. They are attached to each other because of opposite charges. Therefore, if I have, for example, chlorine in my medicine and I have salt, then it will be much easier to create inorganic ion salts, which happens via the precipitation because of the opposite charge. All the methods of drug administration are, for example, when someone has dysphagia, dislike of the taste of the drug, whatever. So knowing that, the best way to have a drug is with water, and that is not equal to food or beverages, because food and beverages can compromise the stability of the drug. So for example, you don't like the taste of the drug and you cannot swallow it by yourself because you have principle of dysphagia. Well, you will probably take it with food and beverages, and you have to keep in mind that these can interact with the drug. Beverages, fruit juices, not with alkali drugs, because fruit juices such as apple and orange, they are acidic. Therefore, we're going to have an acid-base reaction. Milk, it has enzymes. Homogeneity and opacity of the milk will not be in favor for us. We're not going to see if the drug is diluted. And tea is not good for drugs that contain iron, because the tea has tannins, and tannins lower the iron absorption. With soft drinks, we have a few studies only, and there is less acceptance, but in some ways, in some studies, in some drugs, it may have improved the absorption. Again, the best one is the water. Talking about semi-solid foods, apple pudding. It is stable, but we cannot really make sure it is well diluted. Yogurt, widely used, and there are few stability studies. Chocolate cream, not suitable profile because it has a pH of 5, 6. Again, acid-base reactions can occur. And thickeners, only for some, especially dysphagia ones. Moving on, we have the pharmacodynamics, which are the studies in the changes in the drug effect. We talk about here antagonism and potentiation of the drug, direct or indirect. So here, drug effect is the main deal. We can lower the effect, oral anticoagulants and vitamin K. The acinocumarol and warfarin are anticoagulants that will eventually interact with the vitamin K, because vitamin K is a procoagulant. Vitamin K competition in the liver increases coagulation. Continuous intake will have a higher impact. Therefore, we have interactions with foods that are high in vitamin K. Then we have licorice and diuretics, corticosteroids, antihypertensives, and digitalis. The licorice is a diuretic antagonism. Then licorice also will do this, cortisol increase at receptors interacting with corticosteroids. Then there is also sodium retention, which interacts with antihypertensives, and the digitalis, well, we have a potassium decrease that will cause toxicity. On the other hand, we have an increased effect. So the increased effect with anticoagulants and antiplatelet agents happens with some components in onion and garlic that will enhance the properties of anticoagulants and antiplatelet agents. Potassium-rich foods with ACE inhibitors, diuretics, potassium-sparing drugs. Nitrates and nitrates with antihypertensives, such as the nitroglycerin, there is an interaction there. Then also sodium glutamate and diuretics interact with each other. Sodium glutamate is an additive that is put in a lot of Chinese food, and it increases diuretics effect. Foods with high tyramine and monoamine oxidase inhibitors will increase antidepressants, and alcohol and caffeine will in general increase the effect of the majority of drugs. Now we talk about pharmacokinetics, which is the variation in drug quantities and concentration. Again, here we talk about LADME. Absorption lowered by chelate formation. Tetracyclines, which are antibiotics, will be 57% less available when taken with food, 65% less available with milk, and 81% decrease with iron. Chylonones will decrease by 35% with dairy products. Then we have the interaction with bile salts. These, for example, beta blocker drugs, and such as the atenolol, will interact with the bile salts. The effect of the pH. Food with higher pH, conditioning the pKa, will lower the absorption. This, for example, omeprazole will decrease the absorption of iron and calcium. Then we have transporter competition. Need transport proteins, glycoprotein, intestinal cells. So there is a competition there, and the drugs go to the intestinal lumen again. And an inhibition will cause toxicity to this. There is also a case in which we can increase absorption, and this is with low solubility drug and delayed gastric emptying. This will increase absorption, because a low solubility drug is easier to dissolve, and the delayed gastric emptying will make sure that we have more time in contact with the enterocytes to make sure the absorption will increase. There are some effects of food composition as well. So high fat food will increase the solubility and the area under the curve, therefore bioavailability. High fiber food will decrease absorption, and beverages such as milk and tea will decrease the absorption. Juices will change the pH. Cola drinks may increase, and soft drinks are variable. Then distribution, we have binding to plasma proteins, interactions such as competition for proteins, and albumin. This basically summarized is that to travel in the blood, there are some plasma proteins, and there is an interaction via competition, so drug versus nutrient. And the albumin is one of the proteins involved in all of this. Metabolism, we have diets, and different types of diets will dramatically change the metabolism. So high protein will be higher metabolism. High fat, higher metabolism. High carb, lower metabolism. Again, if you remember, higher metabolism means higher cytochrome P450, and therefore higher elimination and less drug effect. Enzymatic induction and enzymatic inhibition. Induction, lower effect, such as in cabbage, cauliflower, broccoli, indole and heterocyclic amines present in oral anticoagulants. Enzymatic inhibition, grapefruit juice, this is very important, and flavonoids as well. They interact with the CUP3A4, which is a part of the cytochrome P450, inhibiting it. Therefore, we have a higher area under the curve, and this will equal to higher antihypertensive. If we have a chronic consumption of, for example, grapefruit juice, we will have higher interaction. So to summarize, grapefruit juice will increase the drug effect by reducing the metabolism. Excretion, we have passive tubular reabsorption and pH changing foods. If you remember, passive tubular reabsorption is done with the non-ionized substances. pH changing foods, we have the urine alkalizers, such as milk, veggies, legumes, fruits, juices and nuts, and urine acidifiers, meat, fish, seafood, eggs, cheese and grains. So now it's time to take a look at pharmacological interactions. Absorption alterations. We have general absorption effects such as physicochemical and physiological variations, pH, osmolarity, gastrointestinal motility, intensity and quantity and nature of the food, The fat effect on absorption is that higher fat, higher drug dilution and higher absorption. And these are present in intraconazole and ketoconazole, which are antifungal, carbamazepine, which is an anticonvulsant, and also in hydrochlorothiazide, which is a diuretic. Effects on delayed gastric emptying. Higher triglycerides in the diet will give us a lower gastric emptying rate and a delay in absorption. This depends on the food composition and quantities as well, and there is a delay in therapeutic effect and degradation of weak drugs. Effects in bioavailability, competitive inhibition, such as levodopa and neutral amino acids, and the drug, which is transported by proteins, will compete with a similar nutrient. This is what I explained before. So there is an interaction via competition for the same protein, nutrient versus the drug. Protective effects of gastrointestinal irritant drugs, non-steroidal anti-inflammatory drugs will avoid irritant effects. Drug solubilization in gastrointestinal fluids. You have to keep in mind that food will dilute the gastrointestinal juices, and higher time in stomach will end up with higher dilution because of the pH and motility. This happens with the diazepam, which is an anxiolytic, the nitrofurantoin, which treats urinary tract infections, and the dextropropofenafine, which is an analgesic. The effects on changes in dissociation. Acidic drugs, non-ionized form is absorbed, pH 1 non-food. Ionized form not absorbed, pH 3 with food. Alkali drugs, non-ionized form is absorbed, pH 3 food. Ionized form not absorbed, pH 1 non-food. So basically here we say that acidic drugs must be taken without food and alkali drugs with food, because there is a higher absorption in those cases because of non-ionized form of the drugs. Effects due to precipitate formation. In antibiotics, the tetracycline, again, they will lower by 50% the absorption because there is a precipitate formation. But this doesn't happen with doxycycline in milk, because it will not interact with the calcium of the milk. In other drugs, we have minerals and bisphonates. This will equal to precipitated chelates. In for example, penicillamine with calcium, iron and zinc. With fiber, well, fiber will always decrease the absorption of, for example, statins and hypoglycemic agents, because fiber will trap the nutrient, or in this case the drug, impeding the absorption. With phytic acid, it blocks absorption of minerals such as iron, magnesium, copper and zinc. With tannins, there is a precipitation with antipsychotics, which will lower the absorption by 90%. And with oxalic acid, well, the oxalates and vitamin C in the kidneys will create kidney stones eventually. Distribution alterations, we have drugs together with plasma proteins. Therefore, high protein diet will create protein competitiveness and higher feed drug and higher effect. Because if we have more proteins, more nutrients, there will be more competitiveness and therefore less drug bound to the protein. Then with fasting, fat with plasma proteins. So we release our own fat, our body fat. There is a competitive inhibition. So therefore the fat will compete with the drug for the plasma protein. There is a higher percentage of free drug and therefore higher effect. Protein malnutrition will lead to higher free drug, which is toxic. And we have to keep in mind that to readjust the dose of the drug. For example, the Kwashiorkor disease is very important because it will produce toxicity. There is not so much protein available to transport all the drug, and therefore toxicity will happen. So we have to readjust the dose of the drug. Metabolic alterations, we have the liver cytochrome P450 and in particular the part of CUP3A4. And we interact with that. Phase 1 is polarization and phase 2 is adhesion, as we talked about before. Therefore, lower proteins, lower metabolization, higher effect of the drug. Higher proteins, higher metabolization and lower effect of the drug. As you can see here, we have the reverse compared to the distribution alterations. Here we talk about paracetamol, which you have to know that more than 4 grams will trigger the quinonane, which will bind to hepatocytes, which are the cells of the liver, and cause necrosis, which is the death of the cell. And more than 10 grams of paracetamol in one day will be fatal, causing too much necrosis of the liver. So, higher proteins, higher metabolization, lower effect, not in paracetamol. This is the only case we cannot really do anything about that. Just don't take that much. And also, if you take more protein, it will be more effective. Then the omega-3 will induce the P450, decreasing the effect. Vitamins are directly correlated with the metabolism, so lower vitamins, lower metabolism, lower cytochrome P450, and higher effect. Non-nutritional components such as BHA and BHT will increase the P450. The indoles in the cauliflower, for example, are enzyme inducers. The phenolic compounds will decrease the metabolization. The naringin in the grapefruit juice, again, this is why, will decrease the P450, increasing the drug effect, and the polyphenols in the soybean will decrease it as well. Dietary and environmental contaminants also can alter the cytochrome P450. Excretion alterations, we have the pH variation, ionized gets excreted, not ionized gets reabsorbed. Meat and fish will create an acid urine, and vegetarian and citric will give us an alkaline urine. Hypersodium diets will decrease the excretion, and also not being well hydrated will decrease the excretion.